live.
Hello, everybody. Welcome to Hello, everybody. Welcome to this first VCBM only session on feature analysis. My name is Anna Vilanova. I am professor at the Technical University in Eindhoven, and I will be chairing this session. We have 3 speakers today, 2 regular talks, and we have an invited speaker at the end. So I would like to also mention that you are able to ask your questions in Discord in the corresponding channel, so please do that. So with no major delay, I would like to introduce our first speaker. Is Thomas Schultz. He's going to present from Bonn University. He's going to present the work developed together with Torayev Agajan in interactive classification of multi-shell diffusion MRI with features from a dual branch CNN autoencoder. So please go ahead.
So thank you very much for the kind introduction. So to motivate this work, let's consider the problem of medical image segmentation. So of course, we need to be able to do segmentation for many visualization tasks, but also for quantification. For example, if you want to measure hippocampus volumes in brain MR, you would have to do a segmentation first. Now, fortunately, in some sense, doing segmentation has become relatively simple in recent years, because now we have very powerful CNNs that we can just take off the shelf. And if we give them sufficient training data for the specific task that we want to solve, they can pretty much do it out of the box. But this is still a pretty major if, especially in case of medical imaging, because the people who have the domain expertise to do the annotations, usually they have very little time to do them. So still getting these annotations is a big issue. When we're talking about 3D data, it would be very time consuming actually to go through the data slice by slice and annotate each and every slice. Fortunately, this is in general not needed because subsequent slices are quite similar to each other. There's a high redundancy. Often you can get away with doing sparse annotations. And for this, even there are state-of-the-art methods like the 3D UNet, which are specialized for this, for making volumetric segmentations out of sparse annotations. The big drawback of these state-of-the-art methods is that training them can take several days. So it's also for the workflow, when you do the annotations, you don't know, did you annotate enough? Then you have to wait for the network to train and check again and start correcting. So our idea was that we wanted this to be much more interactive. And this can best be shown maybe with this video. So here our goal was to segment the left corticospinal tract. So we start by doing annotations just on 2 slices of the CST and the background. So then it's the first time when we can check the classifier result. We eliminate some false positives. We realize still there's a gap in the segmentation in the center between the 2 slices that we annotated. So there, maybe we should annotate a little bit more. And then we can again check the new result. And of course, you could refine this further, but it's a relatively rapid way and interactive way of building the segmentation. So this is what we wanted to achieve in this project. A second motivation for our work comes from the visualization of diffusion MRI. So diffusion MRI is a non-invasive imaging modality that has a quite unique ability to break the resolution limit that we typically have in traditional MR. So we can use it to investigate fine microstructure below the resolution limit, which allows us to do these tractography images that you might have seen, which just reconstruct the trajectories of major white matter tracts. But it also allows us to compute biomarkers that quantify aspects of brain tissue microstructure and maybe detect subtle signs of disease. Diffusion MRI, in fact, is not really one homogeneous uniform technique. There's been many variants of it proposed over the years. The most simple being diffusion tensor imaging, which allows you to do some basic single fiber tractography, compute some basic biomarkers such as FAMD. Over the years, people have realized that in a substantial part of the brain, we have these crossing fibers, and we need to do measurements with higher angular resolution to resolve them, to be able to track through these regions. And even more recently, now with more modern scanners, we have the ability to even do multi-shell measurements. So to measure essentially hardy at multiple levels of diffusion weighting to the even more advanced microstructural models. So there's this complete zoo of diffusion MRI methodology. And in general, as we advance from the top of the slide towards the bottom, the information density, the amount of information that you have at each voxel location, it's greatly increasing. And our choice of visualization tools is really getting very narrow for these more advanced techniques. So this is also a specific application motivation for our work. So we wanted to contribute a direct volume rendering technique that is pretty much universally applicable for diffusion MRI. So the existing techniques, of course, there are already some. They are model-based, based on the specific diffusion tensor model or based on doing diffusional kurtosis imaging. What's special about our method is that it's general, it's because it's data-driven, it doesn't rely on any specific acquisition scheme. No matter what it is, you can use our method to do a classification, essentially an image segmentation, and based on this, define a transfer function for direct volume rendering. Which brings us to the three main contributions in our work. The first was to design and implement an interactive tool that we can use for doing this kind of interactive classification of diffusion MRI data, as you just saw it in the video clip. Then we compared some traditional feature representations with respect to how suitable are they for classifying this type of data. And finally, the contribution where most of our effort actually went into is that we made a novel approach for doing these types of interactive classifications that on one hand is able to leverage the representational power that you can get with convolutional neural networks. On the other hand, it combines this with random forests to give you this interactive experience. And this was not quite trivial, so we also present an evaluation of three of the main design choices that came up during this process. So let's start with the first contribution. Again, it's easiest to explain it in a video. So here are the standard RGB color codings where the color reflects the principal fiber direction at each voxel. Also, if you want to see them for reference, you could look at tractography results. So here again, we have a tractography of the corticospinal tract. And if you want to see very in-depth per voxel information, you can go for these fiber orientation distribution glyphs, which have peaks which indicate locally the directions of the tracts. So this allows you to delineate very precisely how far should the segmentation annotations go. So all of this is integrated in our interactive framework. And something that is special also about classifying diffusion MRI is that because of these crossing tracts, we don't have mutually exclusive class labels as we have in many other semantic segmentation tasks. It can perfectly be that a voxel belongs to multiple classes. And this we reflect, of course, in our design, but also in the visualization. So here we use isosurface slabs to show the segmentations. So here, for example, you see that the corpus callosum, which is shown in red here, it intersects the corticospinal tract, which is now highlighted in blue. The second contribution was to compare which feature representation should we now use as a basis of this classification. For this, we had to decide on an experimental setup that allowed us to really compare different feature sets. So we took data from the Human Connectome project. It's relatively high resolution, and it also has 288 measurements per voxel. So this is really information-rich, high information density data, quite complicated data. Making reference segmentations is very time-consuming. Fortunately, we could reuse ones that have been published by another group from Heidelberg, by Wassertal et al. So they went through a lot of manual effort to curate tractography results for 72 tracts. Of course, trying to get all of them in one single interactive session, it's not a plausible task. So we had to distill, we reduced it into smaller sets, more feasible sets. The first one had the cingulum, the corticospinal tract, the fornix, and the corpus callosum. And here we kept left and right parts of the fiber tracts combined in one class. So we had 4 fiber classes and 1 background. In the second set, we had the IFO, ILF, and SLF, but we kept left and right separate in this case. So that gave us 6 fiber classes. For the classifier, we actually had a very detailed comparison of different ones like support vector machines and many others in a past work where we've just checked which classifier is most suitable for this interactive classification. And we decided back then to settle on the random forest, and we just stick to this design decision also in this work. For the training to simulate these sparse annotations, we only used the labels from 3 slices. But then we wanted to see is the classifier able to generalize from these sparse annotations to the full volume, because this matters also for the visualization in the end. In terms of metrics for the evaluation, we looked at precision, recall, and also F1, which combines precision and recall. We found that in our experiments, all of them were highly correlated. So you can find all the in-depth numbers in the paper. For the purpose of this presentation, I'm just going to show you F1 scores. And essentially, if you would look at the others, they would tell the same story. And finally, in terms of these traditional features, we compared naively using the raw 288 measurements per voxel to using 2 domain-specific. Now, this would still be model-based features, which are just often used for modeling this diffusion data. One is called Shor. So this is based on a harmonic oscillator. One is called kurtosis. And then we also tried a general purpose feature extraction technique, PCA, where we optimized the dimensionality and the normalization to get the best possible classification results. So in a nutshell, this slide summarizes the experiments and the results that we got. So it turned out in this table, you can see that we cannot really improve in terms of the accuracy over using the raw signal by using these domain-specific features. The accuracy is still similar. Often PCA does a little bit better. It somehow seems to distill more the essence, what is important for the classification out of this data. Where all of these features, PCA features and domain-specific features, are superior to the raw signal is really in terms of the training times, because with the raw signal, you have still a quite high-dimensional feature space, and it's faster to train if you reduce the features beforehand. Now, if we look at the bottom of the slide, you can see a visual comparison of the results. And I would say that none of these results are really satisfactory yet. And of course, the reason for this is that with all of these features, still we're using purely per voxel information, whereas it's quite natural that for a more reliable segmentation, we would have to account also for spatial neighborhoods. So how to do this? This is actually one of the strengths of convolutional neural networks. They are very good at learning representations that also account for spatial context. But how can we use them in a way that the training itself remains interactive? So this is now the main challenge for the remainder of this talk. This is our third contribution, which you can summarize also in this flow chart. So we start with the quite high-dimensional raw diffusion data. Then we feed it into a CNN. But the CNN, we want to train it in a pre-process so that the user doesn't have to wait for it. And that means we cannot use the class labels yet because the user has not specified them. So this network we train as an autoencoder. So an autoencoder just tries to reconstruct its own input based on a condensed, concise bottleneck representation. And this bottleneck representation, then we're going to use as a feature vector for the random forest, which does the interactive classification because it's so much faster to train. Okay, so this is the basic idea, to use a hybrid approach where we make use of CNN features, which we can pre-process within the random forest. Now, a technical challenge in this is that within such an overall framework, we cannot just reuse the standard CNNs that you would typically use for image segmentation, because many of them, they are not well suited to be trained as autoencoders. They have very complex decoders. They might lead to very high dimensional representations. So we had to come up with our own architecture that is specifically suited for playing well then with the random forest classifier. So we actually tried quite a few different architectures, and this is one that we finally settled on that worked quite well. So let me briefly walk you through it. We start at the top left with coronal slices of our data, 2D slices, but still at each voxel we have 288 measurements. And then we pass it through two different branches. On the top, we just have one-by-one convolutions. So here still in the top branch, what happens in a voxel stays in a voxel. It's very similar to what the PCA does. It just reduces to the dimensionality from the 288 measurements to 22 features. It distills the essence of the information from it. And unlike the PCA, it does so in this multi-layer fashion where we have the non-linearities in between and in a gradual fashion. So it can find a little bit more complicated mappings than the PCA. And now for learning the spatial neighborhood, what's really crucial is the lower branch. So in the lower branch, to account for the spatial neighborhood, we use 5x5 convolutions. And to allow the receptive field to grow more quickly, we also use strided convolutions, which effectively downsample the original image resolution. So in the extreme case, in the bottleneck here, we just reduce the complete spatial information to just 6x6 pixels, which we then upsample again to the original resolution. And then we can concatenate the features from the upper branch, the per voxel information, the lower branch, the regional information. As we train the autoencoder from this bottleneck representation, we will try to reconstruct the input. Later on in interactive classification mode, we take the same 44 features per voxel and we feed them into the random forest classifier to do our classification. So this is our proposed architecture. Here you can see the quantitative results now on both sets. You see that always the CNN-based features do best because they can account for spatial context. You see that in many cases it's a factor 2 or even more than a factor 2 in terms of F1 score where you get a benefit. For the training times, I would say it's comparable. It's a little bit longer because it's a little bit higher dimensional, but still it's perfectly feasible within an interactive session. Now, if we look visually at some of the results below, I guess everyone would agree that the results also look a lot better. Of course, you might say they are not perfect, right? Here in the IFO, we have a gap in the segmentation. Here in the SLF, obviously parts are still missing. But remember that these are still segmentations based on very sparse annotations. So the idea of this whole approach, of course, is that then you can check it visually and then you can interactively refine. This is the idea why we also want to make everything work out interactively. Okay, so in the overall design of this, there were three somehow challenging choices that I want to walk you through. And we did some additional experiments to verify that we somehow made the correct choices there. The first one is this decision to just feed in 2D slices of the data, even though the data by its nature, of course, it has a 3-dimensional structure. And on first glance, it might appear that there should be an advantage of making use of the full context in all 3 dimensions, not just in 2 dimensions, especially given that the implementation is actually not really more difficult. You can just use 3D convolutions instead of 2D convolutions, and you would get a 3D counterpart. We did quite a number of experiments. We'll have to point you to the paper for all the details. Just in a nutshell, what I'm now highlighting in blue are the best results that we managed to get with the 3D architecture. What I'm highlighting in red is the proposed architecture that just makes use of a 2D context. And you see that in terms of the accuracy, always the 2D architecture wins. Also, it's much faster to do the pre-processing, which can partly be explained by the fact that for the 2D architecture, you need much fewer parameters. And we believe the main reason why still the 2D architecture does better is that it allows you to have a larger radius of the receptive field. So this refers to the neighborhood over which you can integrate information, which for the 3D architecture is a cube of 29 voxels, whereas for the 2D architecture, it's a square of 125 voxels. And apparently using voxels that are further apart is more important than making use of the third dimension. And we cannot simply increase the receptor field in the 3D case to the same, to 125 cubed, due to memory limitations, because already now the number of voxels in our receptor field in the 3D case is much greater than in the 2D case. And even with 11 gigabytes of video RAM, at some point you just run out of RAM. Okay, by the way, this is also the choice that others who are processing this data with CNNs have taken. They, at the current state of the art, most people would use 2D architectures. The second main design decision was to use these two branches. That's very characteristic of our architecture. So of course, we also evaluated if there's really a benefit from this. And we found that yes, in terms of the classification result, you can do best if you account for both. Interestingly, just using the upper branch does better in terms of the reconstruction error for the autoencoder. But here we notice also that these are separate things. What works best for reconstruction does not necessarily work best for classification. So then the question arises, is it even a good idea to train an autoencoder if what we ultimately want to do is classification? So also this we tested, and it turns out that training the autoencoder is really helpful. So even without the training, just due to the structure of the network, we can often outperform even the PCA-based features. But after training, the performance goes up actually significantly. We would be able to do even a little bit better, of course, by using a supervised loss, a classification loss that actually optimizes the features with respect to discriminability. But then you notice that this takes around 6 minutes. So that is no longer possible in this fully interactive setting. Okay, so finally, we did a brief case study to also evaluate this in an interactive context. So we asked a fourth-year PhD student to segment, again, the left CST with the CNN-based features, with the PCA-based features. You can see already from the markers here that he had to put a lot more markers for the PCA. He really had to fight with the system a lot more. And despite this, after the time ran out, the result that he got with the CNN was much better. Okay, so to conclude, we implemented an interactive framework for classifying high-dimensional volume data. It's model-free. Therefore, we can use it for all types of diffusion imaging, even multi-shell diffusion spectrum. It should even work if you have other types of high-dimensional volumes. There's been quite a bit of work on painting-based transfer function design. So ours, to my knowledge, is the first that makes use of CNNs, and we use this hybrid architecture to make sure that it still remains interactive, because training CNNs is costly. And we evaluated this CNN architecture in quite some detail. Now, as future directions, it would be interesting to try and refine the features, maybe in a background thread or on a second PC, on a second GPU, as the interaction is going on. We want to try also maybe using this to create training data for automated 3D segmentation. We have some code on GitHub. And finally, I would like to thank the DFG for funding, the HCP for providing the data, Mohammed for being the guinea pig in our case study, and of course, all of you who are watching the stream for your interest in our work.
Thank you. Thank you, Thomas, for this nice presentation of your work. Quite complex problem you are dealing with. I see that I will ask a question while the audience is warming up to ask you a question. We have a few minutes for that. So one question I would have is, you are using training for your data, and you have this ground truth that you take from people who has delineated. So how to generating ground truth in this setting is not always
No, your stream has frozen. I no longer hear you.
Very easy. Oh, I'm sorry. Can you hear me now?
Yes, I hear you again.
Okay. So are there, do you think that your results are biased towards the methods that were used to generate the ground truth? So if to generate the ground truth, for example, they were using just diffusion tensor imaging, for example, can it be that this influences also your results?
So if you think, would we get exactly the same results with just diffusion tensor imaging?
No. No, so
I guess to me the interesting question is, would our method still work better than just using PCA or diffusion tensor coefficients for classification? And for this, I'm perfectly confident because we're making use of spatial neighborhoods. So
yeah.
I think always using spatial neighborhoods is going to be superior to just using per voxel information.
Mm-hmm.
And our technique is essentially one way of learning a low dimensional description that accounts also for spatial neighborhood information, and that is low dimensional enough that you can feed it into a random forest classifier so that it can make use of it and train relatively quickly.
Okay. But you are evaluating in relation to a ground truth, right?
Yes,
from
of course.
Heidelberg.
The
might
exact
be
setup
defective.
that the exact setup that we're using here, we had to use some ground truth, but I would say maybe let's go back to this. Also, the margin between just using, say, PCA or and the CNN-based features, it's so large. Of course, you wouldn't get exactly the same numbers if you would do the setup differently. Okay. But I'm quite confident that for any reasonable setup, features that make use of the spatial context are going to outperform those simpler ones. Okay.
So I got a question now from Charlotte in Discord. Mm-hmm. So did you also look into making the autoencoder variational? He says, see the work of Kingma et al. That is applying normal distributions to the Latin space.
Yes, indeed, we did. And we didn't manage to get a clear benefit out of variational autoencoders in the context of our work. It didn't increase the classification accuracy. So one motivation that people usually have when they consider variational autoencoders is that they want to have a generative model. And it seems to me that in our application, maybe it's not that crucial to have it. So we looked into it. We didn't manage to get a benefit. Yeah, always the design space is extremely huge, so I cannot say for sure that it's completely impossible. Maybe if you do it differently than we did it, still you might see a benefit. But also to me, it's not that clear why there should be one. We also tried. There are some losses that try to enforce this latent space that you're learning, that try to enforce it to be more clustered. Which to me there was a stronger intuition why this should be beneficial, because we want something that is able to discriminate between different classes. So also this we tried, but again we couldn't improve the results. So in the end, these two things we didn't even report in the paper because for us they didn't give a clear benefit.
Okay. Okay, thank you. Given time, I will stop. There is another question in the Discord. Maybe Thomas, you can have a look and answer.
Sure.
Offline.
Yeah.
Okay. So I would like to move to the next speaker now. That is Martin Falk. He's going to present a paper from the University of Lundström in Norrköping. The authors are Martin himself, Patric Ljung, Claes Lundström, Ynnerman, and Ingrid Hotz. And the paper is Future Exploration in Medical Volume Data Using Local Frequency Distributions. So Martin, please go ahead.
Thank you, Annie, for the introduction. And welcome to my talk on using local frequency distributions for volume exploration. Let's start with some terminology first. On the left-hand side, you can see the underlying data. And if we start binning the data, then you would end up with what most of you refer to as a histogram in the lower right. But in principle, the histogram is basically just a visual representation of the frequency distribution, which is a set of the bin counts of occurrences from our binning. Since we are dealing will be dealing mostly with the underlying data in our work. I will be referring mostly to frequency distributions and less so to histograms. In addition, we will be referring to the concept of local frequency distributions, which is basically you compute a distribution for just a small subset of the data. Here we have the upper left quadrant, upper right, and so on. And as you can see, they're already quite different. And if we're overlaying them each other in a histogram and comparing them to the global histogram, you will see quite significant differences. Of course, we're not the first ones using local neighborhood information. There have been some previous work on, for example, partial range histograms, alpha histograms, or even incorporating small spatiotemporal neighborhoods to facilitate the visual analysis of, for example, ultrasound data. In addition, histogram features themselves have already been used for years for example, for object identification by considering only parts or features of the histograms and consider these distributions as characteristics. One dominant application area in the field of medical visualization for a histogram is typically the case of volume exploration. Here you see an example, volume rendering on the left, histogram in the transfer function editor on the right. And yeah, you see one major peak here, but these histograms are not always telling you the full truth. For example, here, by just adding one primitive here to the right of the peak, we can suddenly see the hidden structure. So this structure was not visible or visible in the histogram. So there has been some previous work, like for example, the alpha histograms. They utilize the concept of local histograms and then basically provide a weighted sum to create another shape of the histogram, which then also reveals the feature of the internal structures. However, as most of you might also notice or know, that a single point in the histogram or the distribution can also correspond to multiple features in the data domain. Here, for example, by just adding this primitive and making everything white, we get the structure here, but then we also have a lot of noise still visible in the volume rendering, which we might want to suppress. So in this work, we want to extend the concept of local frequency distributions, and we want to establish a consistent link between these frequency distributions and their corresponding origin in 3D space, which in turn then allows us to perform some clustering on these LFDs. And then we can present these clusters to the user and then allow for interactive exploration. Like here, for example, we select the major peak or the secondary peak, revealing the hidden structure. In the internal, the pipeline of our approach looks like this. So the main input for the pipeline is the volume data set, which is fed into a pre-processing step and also into the interactive exploration. So let's start with the pre-processing. First, we need to define subregions or subvolumes of the data. So we can compute these local frequency distributions, which we then can compute. We split them up and then can apply some clustering methods on those, the results of which are then used also as input for interactive exploration. Talking about subvolumes, the immediate question coming to mind is, how large should these subvolumes be? So in this example here, it's the same as in the introduction. We have a volume dimension of 192 cubed voxels, and we have this vessel structure hidden inside. On the right-hand side, you can see the results for different block sizes, so ranging from 8 cubed to up to 24 cubed. And as we'll note, the sizes of 8 and 12 work best in this case, which is due to the fact that the vessel structure hidden inside the volume actually has a cross-section of roughly 12 by 12 voxel. So in a sense, these block sizes here correspond to the features we are looking for. Larger block sizes still are able to capture the rough shape of the structure. However, some minor edges or corners might be missing since those are have too little impact on the local frequency distributions. In case you're wondering about the jaggedness, this is due to the fact that we are just showing the pure selection, and for visual purposes, we can then also smooth the outcome to receive nicer looking images. Once we have determined an appropriate block size or let the user decide one, we can then compute the local frequency distributions and then have a closer look at those. Here is one of such. As you can see, this one here has two dominant features in attribute space, that is, not in the physical space. So basically we consider everything which is a major peak a feature. By applying some smoothing or low pass filtering, we obtain a smooth representation, which has one enormous benefit, and that is, according to the work by Ljung and others, a smooth distribution is identical basically to a mixture of Gaussian distributions. So this means that we are now able to detect those peaks and then applying the algorithm by Ljung and others to determine the support of potential Gaussians, and then we are actually able to determine the parameters for individual Gaussians, which then in turn allows us to split up the frequency distributions into multiple parts so that each of these parts just contains a single feature. Worthwhile noting here is that these features are still referring back to the position in 3D space from where they are originating from. Having now split up these frequency distributions, we can now apply some clustering. We decided to go for a hierarchical clustering approach in contrast to k-means. This has the following benefits. First of all, we don't need to know the number of clusters we're looking for in advance. So that's entirely dynamic. And in addition, the hierarchical clustering allows us later on to explore the hierarchy in multiple ways, as you will see in a minute. The downside being, of course, since it's a hierarchical clustering, we need to compute a similarity matrix, which can consume quite a lot of memory. In order for the clustering to work properly, we require a distance metric, which is composed of a similarity measure from the frequency distributions, more on that in a second, as well as then other metrics like, for example, the spatial distance in the physical domain if we want to have close by features clustered together. In addition, the clustering also requires us to compute a representative curve per cluster. We are using here a bottom-up approach, which means that the moment two clusters are combined, we need a curve representing those two. And that basically means that having clustered all the representatives together, we will end up with something similar to the global histogram, which we started with. One might think or wonder why not using the Gaussian parameters directly, which we have determined on just the previous slide. The thing being is that, that we have the assumption of the Gaussian mixture model. We split them up into individual features, but when we recombine those features during clustering, we either end up with a Gaussian mixture model again, or a single Gaussian combining those two, which doesn't fit either well enough. So that's why we decided to go for using a similarity measure based on the pairwise density distance between these distributions, which was proposed by Cow and Petzold in 2006. Here we basically take the pointwise difference between the distributions and then build a sum over all of these. This proved to be quite successful, and we have also tried some other metrics, like for example the Bhattacharya distance, which produced very similar results. So we stuck with the density-based distance. Now we basically covered all the basic building blocks of our pre-processing. So we have learned how to divide the volume up into multiple bricks. We compute the frequency distributions and then are able to cluster these. The clustering is can now be used as input to the volume exploration, where the user is able to select one or multiple frequency distributions or cluster representatives. And now the question is, how can we map that into or combine that with our volume rendering? We chose to use a volumetric mask, which then can be easily combined with, for example, volume raycasting with minimal effort. And this is how it looks. So assuming we have a selection of frequency distributions here, for example, we have the red cluster and resulting in this mask, the green cluster in such a mask, and so on. We have a binary mask. Since each of these frequency distributions or features still refers back to the 3D space, we can then select the entire block. Of course, since our block resolution is rather coarse compared to the volume resolution, the binary mask is rather coarse. And to avoid this problem or lessen this problem, we then can also apply a distance-based transform to basically smoothen out the transitions, as you can see on the right-hand side. During volume rendering, we can then use this masking volume, for example, as a plain alpha mask. So we are able to just highlight the selection represented by that current cluster, like here, shown here. Or we then can also go ahead and, for example, desaturate the other regions, like shown in the bottom. Reference image, as you can see, is in the upper right. In addition, we can then also apply a spatially constrained transfer function to just the selected region and combine that with the previously applied transfer function. So here we decided to highlight the selected region with the bright orange. And then, of course, we can also combine that with the overlay and the alpha masking, which is basically everything here shown on this slide is adjustable by the user. So now, how can you select these frequencies, distributions, or features? So the most obvious solution to this is presenting the user with all of these distributions and then allow him to select them. Here we have an upper torso data set, and by simply creating a rubber band selection on these obviously seemingly outliers, we can select the corresponding 3D blocks. And here, by chance, these blocks actually correspond to the tumors hidden inside the liver. The other way for selecting these distribution and features is to make use of the cluster hierarchy, which basically allows us to either traverse the cluster top down or bottom up. If we have a look at the bottom up approach, this more closely resembles a similarity-based selection. So in order to facilitate this, we provide the user with a slice view where you can select a small region or position the cursor, and then this is reflected here in the lower left side here. That's the initial selection. And then by decreasing the similarity threshold, we get more and more similar clusters selected. So in the middle image here, you can see that we are actually able to, just based on the distribution from this small point here, to select similar regions corresponding also to tumors. But of course, if the dissimilarity is too big, then you will get more and more artifacts since more and more of the volume data set is selected. The other way to explore the volume is then, of course, top down. Here we present the user with a variable number of top clusters. So here we have decided to show 6 dominant clusters. In the lower left, you can see basically the representative curves and the convex hulls of each of these clusters, which then the user can select. Here, for the liver data set, these correspond to the blanket, the examination table, as well as the lung, depicted here in the middle, and then different types of tissue. What you will notice here is, again, the drawback of having just a binary mask. So the results look rather blocky. And also worthwhile pointing out here is, since we split up the frequency distributions into multiple features, that means that some of these blocks can actually be part of multiple clusters. Once we have then identified a suitable cluster candidate, we can then traverse the hierarchy down and then drill down and also follow down the cluster hierarchy, and then also end up in this case with the tumor candidates. The user interface is rather simple looking. The main component here on the left-hand side is the volumetric rendering with the ray tracing or ray casting. Next to it, we have a slice-based view for the similarity-based selection. And in the bottom right, we basically have a slightly enhanced transfer function editor, which in the background allows for interacting with the various cluster representative curves. Here is another example of a hard data set. On the right-hand side, you can see again the various cluster representatives, and then just by hovering or selecting those, we are able to select the corresponding frequency distributions and hence the matching selection in 3D. Here, for example, we have selected just the space around the lungs, which contains a lot of air, so it's quite easy to select. Here we have some tissue types clustered into various two different clusters, as well as this feature here, which actually corresponds to a contrast agent, which was injected into the left ventricle. To sum up, I have presented a novel method for volume exploration using local neighborhood information based on local frequency distributions, and we maintain a link between these frequency distributions in the attribute space and the spatial position in the data domain. And as has been shown before in related work, like for example, the alpha histograms, the use of local frequency distributions or histograms actually reveals more features compared to just the global histogram. We then use these feature distributions to define a similarity-based metric, which allows us to go for clustering, and then the output of the clustering in turn allows us to define features both automatically and interactively, depending on the chosen selection mode. For the future, we are considering extending this work also to more inhomogeneous data like MRI or ultrasound, since so far we have only considered CT data. And then, of course, there's the question of how to choose appropriate block sizes. Since I have mentioned before, at the moment, the block size is depending on the feature you're looking for, which in turn means you need to know what you're looking for. For most of the data sets, we have found an appropriate block size of 16 by 16 by 16 or even 24 cubed, which works reasonably well in most cases. With this, I would like to conclude my talk. Thank you for listening, and I'm open for questions.
Thank you very much, Martin, for the nice presentation of your work. So now we are open for questions. I have a question in the Discord. So a question is whether there is a Git repository or something like this where your code is available. Mm-hmm. One of the people listening to your talk would be interested in using your work.
Unfortunately, not as of now. So even though my work is part of the in vivo framework, it has been in the making for quite some time, and so it's at the moment the code is heavily outdated. So they need some updating before we can make that one publicly available. Yeah.
Okay. Maybe the authors could, the interested people could contact you if they are interested.
Yeah, for sure.
You would be, okay. Well, so I think people is congratulating you for your talk on the chat. I would have a question. So you are talking about extending your results to MR or so. So how do you think your work is working when you have gradient in your images, right? So when you have MRI, then your image has some gradient on them. So could you use what you presented such that compensate for that?
I would assume that the approach somewhat or almost automatically takes care of this, since we're only basically looking for the general shape of these features. So it might be quite possible for the approach to, even if there is a slight shift to the left or to the right, then we are automatically matching those features, since they're still very, very similar in the local distributions. Let's say, for example, if you have, like in the CT case, if we have the bone structure, then it's a very clear peak. Mm-hmm. And even if the density shifts a bit to the left or to the right, we're still able to match that. And I would assume that for inhomogeneous data, that should also be possible.
Yes. Yes, but if I understood it right, you have a global transfer function that defines still the colors and so, mm-hmm. Right?
Yes.
So you're basically using your frequency, local frequency, to make a kind of selection of what you show.
Exactly.
Transfer function. So wouldn't it be possible maybe to combine an adaptation of your transfer function depending on this local? Because I would assume if you have a gradient, you still will have an effect that you don't like there.
Yeah, I think that should be possible. That sounds like a very good idea here. Yes.
Okay, so I see that Lars Lundström has a question for you. How does this relate to compute per voxel some texture measures, such as moments from the voxels and surroundings?
Oh, that's a good question. We actually haven't considered that so far. So we're just taking into consideration the local neighborhood information. So what the basic the underlying idea here, or how we actually discovered the approach, was that we were probing a volume or a slice and have a look at the local histograms, and then discovered, okay, we have quite a lot of similarities. And since we're only using the frequency distribution, we are basically independent of rotation, shearing, and to a certain extent also scaling.
Yeah, but there are moments, for example, that are would be also invariant to all of those, right? So,
yes. Yeah.
Or to some of those.
So in principle, we could compute those as well for the blocks and then integrate them into the similarity metric. Yes.
Yeah. Okay. Yes. So given the time, and I see there are no more questions at the moment in this course, so I would like to move forward to the next speaker. Thank you very much, Martin, again.
Okay.
So we move to the next speaker of the session. This is a different talk. It would be great, Florian, if you could share also your presentation. So our speaker is an invited talk, is Florian Grimm. He's a medical doctor for neurosurgery. He got his medical degree from the University of Tübingen. His medical doctor was about whole body MR angiography in patients with symptomatic arteriosclerosis with risk of stratification and prognosis. In general, and currently his scientific interests are in neuroimaging and rehabilitation and robotics, which is very interesting. And I think it's very enriching to have talks like the ones from a medical side in our VCBM workshop. So I'm looking forward to hear your talk, Florian. The floor is yours.
Yeah, good morning. Thank you very much for the introduction and the opportunity to present our work. Today I will present our approaches for the quantification of brain and cerebrospinal fluid in pediatric hydrocephalus. So I will talk rather about the practical problems that we have in clinical routine and our practicability-oriented implementations of machine learning algorithms. So first of all, I will give a short clinical overview. So what means hydrocephalus? So hydrocephalus is a quite common disease which we treat frequently in our clinical routine. It is best to be understood if you look at the routinely performed MRIs. So here we see a normal MRI. Depicted are T2 sequences in different orientations. In those sequences, the brain mass is gray and the CSF component is white. Depicted is also a maximum intense projection, which gives you an idea about the fluid information. So the difference with hydrocephalus becomes obvious if you have a look at the MRIs of this 4-year-old patient. Especially the inner CSF compartments are enlarged tremendously. Physiologically, the cerebrospinal fluid is produced inside of the internal CSF spaces of the brain, the ventricles. That's here. From there, the fluid travels along the brain and is then resorbed in the outer venous system. So often after inflammation or bleedings, an obstruction or a malabsorption of the CSF can occur. And this results in a fluid accumulation and leads to an enlargement of the CSF spaces, to elevated intracranial pressure, and results in an atrophy of brain mass. Clinically, it is often firstly diagnosed by an increase of the head circumference in toddlers. The increased intracranial pressure may lead to headache, nausea, or tiredness, or even to a loss of vision in the long run. The loss of brain mass leads to neurocognitive impairments and development disorders. The treatment of hydrocephalus is usually a task for neurosurgery. The impaired CSF circulation is restored in a neurosurgical intervention. One of the 2 common options is to implant a small catheter inside of the lateral ventricle of the brain. And then the catheter is connected to an adjustable valve. And with another catheter, the CSF can drain inside of the abdomen where it is resorbed. I've brought along some impressions of the operation. So this is what we see inside of the operation. First, we do the incisions, and then the ventricles are localized via intraoperative ultrasound. Here we see the system pre-connected outside of the body. And then all the catheters are placed subcutaneously. Finally, the ventricle catheter is put inside of the brain and connected to the system. Finally, the peritoneal catheter is placed inside of the abdomen and the wounds are closed afterwards. So the second most common option is an endoscopic third ventriculostomy. With this method, especially for obstructive cases, a shortcut between the inner CSF compartments and the outer CSF compartments is surgically created at this location here. So here again, we have an intraoperative view. That's a view within our microendoscope, and there in the working channel, a small glass fiber is inserted, which is connected to a laser. And here we see with the laser, we can slowly treat the membrane and cut with the laser pulses in a very controlled fashion holes inside of the membrane. So we orient through the semi-transparent membrane and identify structures like the mammillary bodies in the back or the pituitary stalk in the front. And then slowly the opening is enlarged. You also may notice the pulsation of the CSF, which is heartbeat synchronous, and then also some small mechanical effort is done to enlarge the opening. Now you see that the membrane has been opened, and you see a flow of CSF throughout the opening. And in the bottom, you may see the basal artery, which is a sign for us that we are at the right spot. So post-operatively, we have to monitor the further outcome frequently. So besides the clinical examination and the assessment of the neurocognitive development, frequent MRIs are performed. For this immediate response of the treatment, the estimation of CSF is crucial. Usually it is just performed by a direct comparison of consecutive MRIs, and this may reveal apparent changes, but is not very sensitive. Clinical measures like the Evans index or the frontal occipital horn ratio set the maximum expansion of the CSF space to the head diameter. The methods are depicted below for illustration, but as you can imagine, they are not very precise. There's a large intervariability, and those measurements only correlate with the CSF and not very much with the brain mass. So because of those disadvantages of the classical method, exact volumetric measures are gaining clinical importance. Not only the CSF compartment, which gives the effects of immediate therapy effects can be evaluated, but also the change of brain mass, which is most effective for cognitive development of the children. Methods for volumetry exist, but they are not really applicable for clinical practice. We are therefore seeking for solutions that can be implemented directly into clinical practice. So in clinical routine, we have quite a good basis for volumetry. In children, frequent MRIs are performed. Usually, we use thin sliced 3D T2 sequences, which provide a very good resolution of around 1 millimeter isovoxel and an excellent contrast ratio of the brain to CSF. For the volumetry, first the extracranial tissue must be excluded, and very challenging is indeed the large anatomic variability which we see in children. So below I've depicted a selection of different patients, and here obviously atlas-based classical methods are not applicable. For this purpose, we started with already implemented algorithms to build up an automated processing pipeline. In this first study, we utilized the FSL toolbox, which we also use in the processing of diffusion tensor imaging. And firstly, the 3D images were reorientated, and then SkullScript using the brain extraction tool within the algorithm. This works on an atlas morphing basically on the brain structures. And in this first step, we mask the inner brain compartments displayed in green. So consecutively, two-class segmentation into brain and CSF is performed with the Markov random field model by the FAST algorithm. So this algorithm is using also the information of neighboring boxes for classification, and no atlas-based information is used for a proper segmentation. And there we have nice results even in a grossly changed anatomy. So going out from those masks, here now the brain is displayed in blue and the CSF in yellow, we can calculate the volumes. So with this automated processing pipeline, we could check for volume changes after the neurosurgical intervention. So in this diagram, the clinical information is given. So we have the volumes for CSF and brain after the intervention, VP shunt and ETV. We could trace the changes after the intervention. You may notice that the difference for ETV is a bit smaller, but that's what we expect out of clinical routine. So although the automation process is comparatively fast, you are still dependent on data transfer and some calculation time. So inspired by the classical indexes, which rely only on 2-day slices, we checked for the information content, which we get out by calculating solely the areas for brain and CSF in one slice. For this purpose, we chose a reproducible layer just above the third ventricle. This is displayed in this slice. So we calculated the area in this axial volume for all the patients and compared it to the volume information we get for CSF and brain. And notably, the correlation for the area and volume is quite good. And we can read the clinical information that we need already out of the 2D slices. To check if this 2D method area determination is also suited to follow at the clinical course, we map the area of the 3D volume and 2D volume in certain cases. As you see, for therapy, the volumes and area can track the changes very accurately. So here we have, in the first row, we have depicted the MRIs before intervention, and then the consecutive scans for every patient. And you may notice that the volume in blue and the area in green is quite parallel in the course of treatment. So with the proposed method, we have a certain platform dependency on the FSL toolbox. We have established both a valid 3D and 2D technique, and a large data set of segmented data is now available. To generate fast results, we saw an ideal application for deep learning algorithms. So to proceed, we chose to keep on the 2D design. As you know, a 3D design would have been possible since we have 3D data sets, but we would expect better segmentation results even with a 3D segmentation. But then again, one must have the complete data set available for segmentation. And as you know, a tremendously different computational power must be in the background. This would be on the cost of the clinical applicability. So for our further design, we chose the VGG16 CNN as a ground structure. So this is an established network for imaging classification, and it offers an excellent visual preprocessing, although it's comparingly hard to train. So this is our network structure. So with the pre-trained ways of the CNN, we built up a quite straightforward encoder-decoder network, very classical. So the diagrams are reformatted and then entered into the RGB channels of the input layer. And with the original geometry data at the end, the areas, respectively, the volumes can then be calculated with the result of the output layer. So these are our training specifications. We transferred the classical segmentation results to the pre-trained network. And the training took place with randomly selected slices against validation slices, which were randomized patient-wise. In this case, we segmented 4 classes, CSF, brain, tissue, and background. And the data was additionally augmented for contrast, brightness, and XY translation. The accuracy was then estimated by randomly selected other data set. And additionally, we performed testing against an openly available artificially created T2 dataset, the BrainWeb dataset. This has a known ground truth. So here I display our classification results. So here in the first column, the native T2 datasets are illustrated, and this is followed by the segmentation results of the FAST algorithm. And here we see the segmentation results of the CNN, and color-coded the differences are given. So all in all, we reached a global accuracy of around 90%. CSF was 86%, and brain around 85%. The classical accuracy markers are illustrated as an overview as well. So the validation against the T2 BrainWeb dataset are illustrated here. And here again, you see the slices of the BrainWeb dataset. Here, the known ground truth of the BrainWeb dataset, and the classification results. So accuracy was comparingly, CSF was a bit better with 95% in the classification. The tissue segmentation was a bit different because it is an artificially created data set, and there we saw some systematic differences to our T2 training data. So again, if we look at the classification results of the 2D data set under therapy, we notice that the results of the CNN and the FAST algorithm are quite similar. So again, we have depicted MRI pictures in the treatment course of different patients, and you may notice that the results for CSF and brain are quite similar with the 2 methods. So what would we expect for a real clinical application? So of course, the application should be reliable, but also on the clinical side, there's a proper need for time efficiency. It should be also usable with a low technical effort, and should to be simply integrated into clinical practice. So right now, we are working on the integration of more imaging entities into the classification network. So T1 images are very important because they are frequently used in clinical practice. And we are also right now extending the algorithm to CT images. They are especially important because in adult hydrocephalus patients, usually CT scans are performed. Lastly, one issue that we are coping with is the susceptibility artifacts, which you see in the next diagram. So the implanted shunt system has some metal parts which produce susceptibility artifacts, and obviously the FAST algorithm can't cope with those artifacts, and the training with the CNN on the FAST algorithm handled that error further. And finally, our final vision is to transfer those algorithms to a smartphone application. So when the patient comes to the outpatient department, that it would be possible, for example, to create a snapshot with a camera on the smartphone and then do the classification directly on the smartphone with a direct output to really generate fast results for the clinicians. So at that place, I thank you very much for your attention, and I'm open to questions right now.
Thank you very much for your presentation and the interesting case of clinical use of segmentation techniques for your problems. So I see still there are no questions in this course, so I will start asking some questions myself. So in your I was wondering, you are presenting now a kind of interest in automatic classification of your results, right? So you still keep showing the results in a rather 2D slices visualization. Is how it's maybe a bit off of what you presented, but how relevant it is for you to be able to orient well when you prepare the operation that you presented, to look at actually this data in a 3D structure, or that's completely not relevant to you?
Actually, for this kind of operation, it's not very relevant. So we have other cases for intravascular surgery where that's getting more important, but the orientation for the CSF system is quite the same. So what we do in clinical routine is just to orient on the 2D pictures.
Okay, and so the kind of visualization would in 3D also would not be needed. Okay, let's see where.
Exactly.
I was also wondering when you use mainly for segmentation. So sometimes it's said that in a clinical setting, it's very important to be able to explain where the results come from. But I think in an application like yours is a clear example in where these explanations are maybe not needed, right? So where you basically are interested in good results and you can just see that. Am I correct there?
Exactly, yes. Mm-hmm.
Okay. Let's see, I see people typing. Okay, so Michael Kron is asking, could it be interesting for you to see the uncertainty of the classification from the ML, from the machine learning? So meaning that you see in which areas the machine learning was uncertain on the decision made.
Obviously, yes. So the classical algorithms, they have been tested on validity. There are some studies on that, and so for clinical validation, it's enough for us. And also we checked the segmentation results manually to have a visual information on that. That's true. Yes. Mm-hmm.
Okay. Do you correct for it as a follow-up?
No, not yet. So we just checked to have a proper information. We had some data sets with a misclassification, but those we didn't take into the study.
Okay. Good. I see still people typing. Yeah, we have a certain delay, so I would like to give the chance also to ask
yeah, sure.
further questions. Maybe we could go on in this direction. Well, I see it's a delay. So when the segmentations are not correct, right? So you say that you usually don't correct for it. So what do you do with these cases then?
There you have a certain problem. Yeah. So the option would be to manually correct it. Yeah. But that's obviously very, very time consuming because those are 3D data sets, and that would be a lot of effort to put in them. Yeah.
Okay. So in practice, it's not being done?
In practice, yeah, for our studies, as I said, we didn't take those misclassifications into it. Yeah.
Okay. So Kai Nisselt is asking, what are the main obstacles to implement the smartphone app? Are the algorithms, for example, still too demanding for compute power?
What we plan with screenshots to do the segmentation on screenshots, obviously the first obstacle is to do some geometry correction and also to enhance the brightness and contrast with it. We are working on some methods to do that from a screenshot. And then basically, if you transform the network to a smartphone platform, then you can basically do the classification on those screenshots. And the obstacles that we have are, and where we have to put in some work, are the suitability artifacts, which I've shown some MRIs at the end of the presentation. And there we do have to put some work on that.
Okay. So we have another question. From your experience as a medical doctor, how welcoming do you think is the medical community to artificial intelligence? Does it vary from country to country? Can you compare the culture and ease of regulations, for example, EU, Germany, North America?
I think it's dependent on what you're trying to do. I think AI is a good solution for image segmentation and also to support in image segmentation to find basic structures, to mask brain mass and CSF, for example. But in my opinion, you always need to have a control behind so that you can manually check if the segmentation is correct, that you're relying your decisions on. And sure, for further applications, you have to do testing in studies, how reliable it is. At our smartphone application in Germany, this is a medical product, and you have to do the testing then before. Yeah.
Okay. And there are different regulations depending on the countries. It's easier to put AI in some countries than others, or?
Yeah, how do you mean?
So one of the questions is, can you compare the culture and ease of regulation? So if you in Germany would be, for example, easier to adapt to AI policies or compared to North America or the USA?
To be honest, I don't know the exact regulations in North America, so it's a bit hard to compare. I just know the German rules for it.
Okay, thank you. Yeah, I see people typing, but and we have time. So, okay, so Thomas, the current system focuses on the post-operative tracking. To which extent could image analysis or visualization help with the interventions themselves?
For the interventions itself, I don't see so much of a benefit. Yeah. Because, as I said, we are classically orientated inside the OR on 2D slices, and the geometry is not that much different for the surgery. The big importance is rather to have the volumetry that you can base your decisions in the course of therapy on that volumetry. So, for example, if you see that the CSF space is slightly increases, you have to adjust the valve of the patient and then change your treatment. But for the operation itself, in this special question, I don't see that much of advantages.
Okay, thank you. So Michael has another question. So in medical applications, do these slices still seem to be the prevalent mode of visualization? Are there any use cases in your application area where 3D vis would be helpful? Why would you say is it not so widely used? So I think it's a bit related to the first question I already asked.
It's a bit a matter of what you're used to. For example, for vascular surgery, the 3D visualization is more important, and there are some studies on that, how to display the vessel with aneurysms or anything in 3D beforehand the operation, that you can do a good planning, that you see how the aneurysm is located in relation to your skull opening, and this really helps you during the operation. So if you have changing anatomy, that's very important. And it's beginning to also play a role in tumor surgery, for example, to see the configuration of the tumor beforehand. And for those applications, we are also frequently using navigation techniques intraoperatively, where you can see the MRI related to your operative situs in real time during the operation.
So would you say that in your case it's because the geometry is rather simple or stable, and the operation itself doesn't require much detailed knowledge of that?
Exactly. In most of the hydrocephalus cases, that's more simple, but we have other applications in neurosurgery where those aspects are more important. That's true.
Okay. Okay. So given that there seems not to be more questions, and at the time also, I would like to thank you, Florian, for your nice presentation. Also, I would like to thank all the speakers for their preparation and the nice talks they have given in this session. And yeah, I thank you all, and looking forward to see the rest of VCBM. Have a nice day. See you.
Thank
Bye.
you very much.